Cardiovascular Disease Risk Assessment and Prevention, BNF Chapter 2, Part 5. Let me start with a question. Most heart attacks don't come out of nowhere. They are predicted years before they happen. The real problem is not lack of knowledge. The problem is that we ignore the warning signs. So today, let's slow down and fix that. When we say cardiovascular disease or CVD, we are not talking about one illness. CVD is a group of conditions. It involves the heart, the brain, and the blood vessels. That means coronary heart disease, stroke and TIA, peripheral arterial disease, aortic disease, different organs, same underlying problem. And that problem is usually atherosclerosis, with thrombosis sitting on top of it. Atherosclerosis is slow, silent, progressive. Thrombosis is sudden and dramatic. That's why CVD looks unpredictable, but actually it isn't. Now, not everyone carries the same risk. Risk is not equal. Men have higher risk. You have family history matters. Certain ethnic groups, especially South Asians, are at higher risk. Age plays a huge role. Risk rises after 50, and after 85, it rises sharply. But age alone does not cause disease, because the most important risks are the ones we can change. These are your modifiable risk factors. And honestly, this is exam gold. Medical factors first. Hypertension, abnormal lipids, obesity, diabetes, then the part many people forget. Psychological risk factors, depression, anxiety, social isolation. These are not soft factors. They directly affect cardiovascular outcomes. And finally, lifestyle, low physical activity, poor diet, smoking, excess alcohol. This is where prevention actually works, not with magic, with consistency. So what is the aim of treatment? Very simple. Prevent the first cardiovascular event or prevent another one from happening. And we do that by three things: lifestyle modification, drug therapy, reducing modifiable risk factors. That's it. No shortcuts, no miracles. Now let's talk about CVD risk assessment. Most guidance comes from three sources: NICE, SIGN, Joint British Societies. They agree on principles, but not on every detail. And yes, exams love that. Let's start with NICE for primary prevention. NICE says, use a systematic approach. Start by estimating risk using existing records. Only do a full assessment if needed. Who gets priority? Anyone with a 10-year CVD risk of 10% or more. And NICE also says, review CVD risk regularly in people over 40, not once, regularly. SIGN takes a slightly different approach. SIGN recommends offering CVD risk assessment every 5 years to people aged 40 and above, but only if they do not already have CVD, do not have diabetes, do not have CKD, and are not already on BP or lipid treatment. SIGN also says assess at any age if there is a first-degree relative with premature CVD or suspected familial dyslipidemia. Now, this part is very important. When should you not use a risk calculator? If the patient is already high risk, that includes patients with established CVD, CKD3 or higher, albuminuria, familial hypercholesterolemia. NICE also excludes type 1 diabetes, other inherited lipid disorders. SIGN excludes diabetes in patients aged 40 or above and younger diabetics with long duration, organ damage, or very high risk. If risk is already obvious, don't waste time calculating it. Now let's talk about risk calculators properly. Risk calculators estimate probability, not certainty, and they often underestimate risk in certain patients. For example, patients on steroids, antipsychotics, immunosuppressants, patients already on statins or antihypertensives, recent ex-smokers. So remember this line: clinical judgment always beats calculator scores, always. The most commonly used tools are QRISK and JBS3, used mainly in England and Wales. They estimate risk of angina, myocardial infarction, stroke, TIA. They include factors like lipids, blood pressure, age and sex, ethnicity, smoking, BMI, diabetes, CKD, atrial fibrillation, treated hypertension, rheumatoid arthritis, social deprivation, family history. Then came QRISK3, more realistic, more clinical. It adds factors like CKD stage 3, migraine, steroid use, lupus, atypical antipsychotics, severe mental illness, erectile dysfunction, blood pressure variability. This matters because real patients are complex. Now, JBS3 has one special strength. It does not stop at 10 years. It can calculate lifetime cardiovascular risk. This is very useful when 10-year risk is less than 10%, but the patient is young, with bad habits. Perfect tool for motivation. Sometimes lifestyle change starts with understanding the future. In Scotland, we use a sign designed specifically for the Scottish population. It includes age, sex, smoking, blood pressure, lipids, diabetes, rheumatoid arthritis, social deprivation. But sign reminds us again, always consider extra risks like ethnicity, BMI, AF, mental health, and physical inactivity. Sign defines 10-year risk, 20% equals high risk. Now, prevention. This applies to everyone. Every patient at any level of risk should receive lifestyle advice. That means a healthier diet, more fruits and vegetables, less salt, less saturated fat, regular exercise, weight control, less alcohol, and stopping smoking. Review yearly. Individualized advice. Prevention is not one size fits all. Now, primary prevention with drugs. First, antiplatelets. Aspirin, no, not recommended. Why? Minimal benefit, increased bleeding risk. Simple. High-yield exam point. Antihypertensives. Offer them if there is sustained raised blood pressure and significant CVD risk. Follow standard hypertension guidelines. Lipid-lowering therapy. First choice, statins. Always statins. Before starting, think. Correct secondary causes. Consider frailty. Check polypharmacy. NICE statin guidance is clear. Offer low-dose atorvastatin if 10-year CVD risk is 10%. CKD is present. Type 1 diabetes, especially if over 40 or long duration. Even patients over 85 may still benefit. Monitoring statins is not optional. Review annually. Check adherence, check lifestyle, measure non-HDL cholesterol. Your target, more than 40% reduction in non-HDL cholesterol. If not achieved, check adherence first, then increase dose if appropriate. Statin intolerance, if a patient cannot tolerate 3 different statins, refer for specialist advice. Other lipid-lowering drugs in primary prevention. Ezetimibe, NICE says yes. Sign says only if statins are unsuitable. Bile acid sequestrants, sign, limited role. NICE, not recommended. Fibrates, only if triglycerides are very high and HDL is low. Now, secondary prevention. The patient already has CVD. This is aggressive prevention. Antiplatelets, low-dose aspirin daily. If aspirin not tolerated, use clopidogrel. In stroke or TIA, clopidogrel alone or aspirin plus dipyridamole. Antihypertensives, treat sustained high BP in all patients with established CVD. Lipid-lowering therapy. First line, high-dose atorvastatin. Lower dose if there is high risk of side effects, drug interactions, poor tolerance. High-dose simvastatin generally avoided. Targets again matter. Non-HDL reduction 40%. JBS3 target, non-HDL 2.5 millimole per liter. If not met, improve adherence, increase dose, seek specialist advice. Additional drugs, ezetimibe add if statin alone is not enough. Icosapent ethyl for patients with high triglycerides and established CVD. Fibrates only for marked hypertriglyceridemia with low HDL. And finally, psychological risk factors. Often ignored, but extremely important. Patients with CVD and depression, anxiety may need psychological therapy or mental health referral. If medication is needed, SSRIs are preferred in patients with depression and coronary heart disease. So this is cardiovascular risk, not memorization. Assessment, judgment, prevention. If this helped you connect the dots, hit like, subscribe, and share it with someone revising BNF. Next part coming soon. Stay sharp.